Alright, so now we are going to start back with factors affecting oxygenation. We have physiological, developmental, lifestyle, and environmental factors. Hyperventilation, hypoventilation, and hypoxia can all affect oxygenation. Disturbance in conduction, impaired valvular function, myocardial hypoxia, cardiomyopathy, and peripheral tissue hypoxia can all affect oxygenation. Anemia causes a decreased oxygenation. Patients may exhibit fatigue, a decreased activity intolerance, shortness of breath, increased heart rate, and pallor. Now, inhaling toxic substances such as carbon dioxide, hemoglobin strongly binds with carbon dioxide, and hemoglobin is unavailable for oxygen transport whenever those toxic substances are inhaled. Hypovolemia can affect oxygenation. Shock and severe dehydration can be causes of hypovolemia. Decreased circulating blood volume results in hypoxia to tissues. Cardiac output increases with hypovolemia because our bodies try to adapt by peripheral vasoconstriction and increasing the heart rate to increase the volume of blood returned to the heart, thus increasing cardiac output. Decreases in the fraction of inspired oxygen concentration are caused by upper and lower airway obstruction, which limits delivery of inspired oxygen to the alveoli. Decreased environmental oxygen, such as high altitudes, or hypoventilation can occur in drug overdoses. Now, increased metabolic activity increases demand for oxygen. When is an increased metabolic rate normal? When is an increased metabolic rate normal? Pregnancy, wound healing, exercise, when the body is using energy or building tissue. With high fever, our body needs more oxygen. With an increase in oxygen production, carbon dioxide production increases. When fever is high and persists, metabolic rate is high, and the body begins to break down protein stores, which lead to muscle wasting. Now, pregnancy can affect oxygenation because pregnancy can affect the chest wall movement because the uterus pushes the abdominal contents up against the diaphragm. Now, dyspnea on exertion and fatigue because the inspiratory capacity declines are common. Individuals suffering from obesity have reduced lung volume from the heavy abdomen, especially when lying down. If someone is obese and after surgery, they have an increased risk for lung issues because their lungs aren't fully expanding and the secretions remain in those lower lobes. Now, if someone suffers from a musculoskeletal disorder, they can suffer from breathing problems because of reduced oxygenation. What would a musculoskeletal disorder be? It could be a congenital disorder. So congenital, it could be aging, such as kyphosis, trauma, or muscular diseases. Now, trauma can play a part in oxygenation, especially when flail chest occurs. Flail chest is in a condition in which multiple rib fractures cause instability in part of the chest wall. Now, the lung is doing the opposite of what it should be when flail chest occurs. Myasthenia gravis and Guillain-Barré syndrome. These affect oxygenation because the breakdown of communication between the nerves and muscles. The immune system attacks the nerves. The central nervous system, trauma to the medulla oblongata and the spinal cord can result in a decreased oxygenation because phrenic nerve damage can occur in C3 to C5. Now, Alterations in respiratory functioning. We have hypoventilation, hyperventilation, and hypoxia. Hypoventilation occurs when the alveolar ventilation is inadequate to meet the oxygen demand of the body or eliminate sufficient carbon dioxide. Patients with COPD or chronic obstructive pulmonary disease have adapted to a high CO2 level. Their bodies think that level is normal. Typically, you'll see them hang out sometimes in the lower 80s, mid 80s, high 80s. Now, if we give them oxygen greater, typically you don't want to give someone with COPD any more than 2 liters of oxygen because you're giving their body something they're not used to, and their drive to breathe can be knocked out. Some signs would be decreased level of consciousness, even dysrhythmias and cardiac arrest. For these patients, their stimulus to breathe is a decreased oxygen level. So when we give oxygen, it stops the fall of oxygen and the peripheral receptors aren't stimulated. Okay, that's for those folks with COPD. Now, hyperventilation is when the lungs are removing carbon dioxide faster than it's produced. Anxiety, drugs, and infection can all result in hyperventilation. Rapid respirations, paresthesias, lightheadedness, and loss of consciousness can be seen with hyperventilation. Now, hypoxia is when tissue oxygenation is not adequate at the cellular level. Some causes can include a decreased hemoglobin level. That means there's a lower oxygen carrying capacity of the blood. High altitudes because of decrease of inspired oxygen. The inability of tissues to extract oxygen from the blood, such as a poisoning. Decreased diffusion of oxygen from alveoli, which could be from pneumonia. Poor tissue perfusion, which could be from shock. And impaired ventilation, which could be from a trauma. Now, in these patients with hypoxia, we might see apprehension, restlessness, an inability to concentrate, a decreased level of consciousness, dizziness, an increased heart rate, increased respirations. But as hypoxia worsens, that rate will decrease. Now, early stages of hypoxia, the blood pressure is elevated unless shock is the reason for hypoxia. Okay, cyanosis is a late sign of hypoxia. We have central cyanosis and we have peripheral cyanosis. Central cyanosis is observed with the tongue, soft palate, and conjunctiva of the eye where blood flow is high. Peripheral cyanosis is seen in the nail beds, earlobes, extremities, and is a result of stagnant blood flow. So central cyanosis would indicate hypoxemia, and peripheral cyanosis would be a result of stagnant blood flow. Now, I know that in the previous audio we went over the electrical conduction of the heart. I do want you to know that dysrhythmias are rhythm disturbances in the heart. They are a deviation from normal sinus rhythm. Tachycardia is greater than 100. Bradycardia is less than 60. There's atrial fibrillation in which there's an irregular rhythm. The electrical impulses originate from multiple sites. The QRS complex is normal, but it occurs at irregular intervals. Ventricular dysrhythmias are when the pulse originates in the ventricle, not the SA node. The QRS is typically widened. Ventricular tachycardia and ventricular fibrillation are life-threatening rhythms that require immediate intervention. Okay. Now, we do have left-sided heart failure and right-sided heart failure. With left-sided heart failure, there's a decreased functioning of the left ventricle. Blood pools in the pulmonary circulation causing pulmonary congestion. Some signs and symptoms may include fatigue, breathlessness, dizziness, confusion, crackles in the base of the lungs, cough, hypoxia, shortness of breath, and paroxysmal nocturnal dyspnea. With right-sided heart failure, there can be an impaired functioning of the right ventricle. It can be from long-term left-sided heart failure. We typically see a weight gain, distended neck veins, hepatomegaly, and splenomegaly, as well as dependent peripheral edema in these patients with right-sided heart failure. I am going to end this audio here, and I will pick back up with myocardial ischemia.